Very good afternoon, and we have this course on refractive surgery, oops moments, and handling complications of all kinds of situations. And we have a stellar faculty today. My name is Gaurav Luthra, and I'll be one of the speakers as well. We have with us Dr. Sonu Goyal from Jaipur, who's doing all kinds of refractive surgeries and presents internationally in almost all forums, conducts courses. We have Dr. Chitra Ramamurthy, who is again a very passionate refractive surgeon, does a tremendous amount of surgery of all laser corrections and ICLs and everything. We have with us Dr. D. Ramamurthy again, who's a master at not only refractive surgery but refractive cataract surgery and premium IOLs. He'll be talking to us about certain unhappy patients and how to manage them. We have with us Dr. Ajay Sharma from Gurgaon, who's the head of the IQ group of hospitals, again, who's prolific refractive surgeon. We have Dr. Kumar. I think he'll be here any moment now. He is from Bombay. He is again he's with over 25 years of experience in refractive surgery, does almost all kinds of surgeries and deals with complications. And we have Dr. Sri Ganesh, who is, we all know what Dr. Sri Ganesh does. He's a brilliant refractive surgeon, pioneer in most surgeries. So I think I'll first invite, should I go with my talk first? Okay, then second you can go. Okay. So since I am on the podium, I'll invite our speakers and panelists to please be on stage. So Dr. Ramamurthy, Dr. Ajay, Dr. Kumar and Sonu, if you would like to come here, and you want to stay there? Okay, after this. So I wanted to share a few oops moments that I've had now. I would like to give credit to my friend Kumar for discovering this term of the oops moments. He conducts a course on oops moments in cataract surgery in ASCRS, and I thought this is only appropriate to bring it along to refractive surgery as well. And I think Dr. Namrata has been conducting oops courses in the AIOS, and they bring out quite a good number of nice ideas. So this is something which, in SMILE, I'm talking about lenticule complications and how to manage them and how to prevent and preempt them. One of my fellows was operating here just about a couple of weeks back, and so fairly good so far. Everything looks nice. We typically want to identify the deeper plane first, and then on the other side we try to identify the cap plane. So far so good. And so they realize that the two planes meet. If the two planes meet, that means we haven't really identified the lenticule plane well. So my fellow is trying to identify under my guidance and trying to see whether we can identify that deeper plane. And eventually he thinks he's found it, and now wants to kind of extend that plane a little bit to one side or the other, and is finding it very, very tough. It's very, very tough. He's not being able to make space. Not, it's the manipulator is not moving from one side to the other. I immediately stopped him there, and now I have taken over and I have identified the plane. So just let's go back for a moment. I could immediately see what was happening. I'll just take you back there. So he's found a plane, which is the lenticule plane, and he's trying to move it to one side or the other, trying to identify that plane. And you can see that he's not being able to move. So what's basically happened is, if you're too enthusiastic, you can actually very easily enter into the stroma and create a false passage. And then obviously the telltale sign is that it will not move much from either side. If you force it, it will move somewhat, but you'll create a tear, you'll create a false passage which extends. So at this point, you have to become very sure that you are not in the wrong plane. So once I took over, I was able to now, here I've gone from another area and identified the plane, and then of course it moves to the side very easily. So this obviously makes it easy. Now I was able to complete the surgery, everything went well, and then at the end of surgery, after removing the lenticule, just to demonstrate, I was able to show that once the surgery is over, the lenticule is out. Now I'll just go and show you which plane had been created. So this is the plane which was created and where my fellow had managed to create a false plane. So this one has to watch out. Let's go to another situation. Sometimes if you have difficulty in dissection, and especially if your lenticule is too thin, and sometimes we tend to decrease the lenticule's minimum thickness to 10 microns, especially, or if you're dealing with a very thin lenticule to begin with, and if you manage to get some dark spots, or you get some situation where the dissection is not straightforward, and if you're not careful, you may cause a lenticule tear. So of course, if you manage it carefully and use the right amount of forces, you will not do that. But here I'm now dissecting the lenticule plane, and suddenly I realized that something funny is going on. I can see a tear happen here. Let me take you back again. There's nothing much that I did except that this lenticule was a thin one. It was about 50 microns. And so as I'm coming to this side, there is some resistance, and as I do that, I find that if you notice here, there is a lenticule tear which is created. So one has to be very observant. It happens very, very rarely, but it can happen. And this can happen if your dissector is sharp. So it's a good idea not to use a very sharp dissector. I have a very blunt one, but still it happened because the lenticule was very thin and maybe there was strong adhesions in this area, and I was trying to force it to this side. So the trick is to break through at 6 o'clock and dissect on either side, and then make sure that you don't have a retained lenticule at 6 o'clock. But here I ended up having a lenticule at 6 o'clock. So I don't have much choice now. I'll have to bring out first the other part and do what you want. You will not be able to find that plane very easily. There's a very clear lenticule tear over there. I'm going to bring out first the bigger part of the lenticule which is free. I'm trying to go get under that lenticule, but it's of no use. I'm staying in the cap plane most often because that lenticule is stuck. So I'll have to probably go in and identify. So here I bring out this part of the lenticule. These are only 1 or 2 of the lenticule tears, so I had to really look for this video because maybe in a 5,000-10,000 eyes, there are only 2 situations where this actually happened. But when it happens, you should know how to deal with it. And if you can't identify it, sometimes it helps to put in triamcinolone into the interface to stain this area. Otherwise, you can see it on the slit lamp or on the OCT. Intraoperative OCT can help you. So the trick is now to find a space where the lenticule has been dissected a little bit. So I was able to find one small area where there was a free area where I could get under the lenticule and over. So the forceps has to be able to catch the lenticule at some place. Otherwise, you'll have to do a circle software and go in. So I was able to identify one area where I could get a hold on it. Now, once you get a hold on it, it's almost like a capsular excess or a lenticular excess, and then you can just move it to one side. So here I'm, again trying to get a grip on it, and then it can be a little messy, but once you get a grip on it, you'll be able to tear it. There. Now I've brought it out. So essentially, you should be able to find a way to grip it, and you have to be very patient. It doesn't happen very easily, but once you find that correct plane and the correct area to hold it, you can do it, and then you can spread it out and see whether you got the whole lenticule out. At the end of surgery, you should check on the slit lamp on the machine and also outside the machine, and maybe do an OCT just to see that nothing else was left behind. And here you can see that we've been able to complete that lenticule by placing it on the cornea and manage it. Another situation, sometimes this is again extremely rare. So these are complications which we saw over the last 6 months, and I was able to put them first here for you because these are new things. A buttonhole is extremely rare, but if you are doing a thin cap and sometimes in area of pannus, especially in the peripheral area where you do this, just see how effortlessly a buttonhole can form. Now I'm doing the deep plane first, and now I'm going to go identify the cap plane. And I'm just going to move this to one side, and there comes. So I managed to penetrate the cap. Now I was wondering why this would happen. My cap was about 120 microns thick. It doesn't usually happen. We do this all the time. But then I realized, and I looked very carefully, this area had a cornea, had some pannus, and this area had a very fine corneal opacity, which had probably caused some thinning in that area. So there was probably epithelium which was filling in. So the amount of stroma was probably very less. And this was unhealthy because this happened in the second eye as well in the same area. But I was more careful, so I could prevent it. But then you have to be careful. So what I'll do now is I'll come back because this can potentially be a space for epithelial ingrowth to happen. I'm going to go from the other side and create the cap plane. So I just went to the other side. So both my planes are identified. I'm going to leave this area alone. I won't come into that area at all except till the end. And then now I'll just go very carefully from the other side. So these are oops moments which help you learn. And I think learning never stops. I've been doing Smile for 10 years, but this thing came up just about a few months back, and one keeps learning new things that can happen when you operate, and then you can share this. And I learn so much from all my other colleagues who bring in their situations, and that's what this course is all about. So very carefully making sure that I don't have anything left towards the end. And in this area, I have to be very, very careful because that buttonhole can extend at any time. The cornea is not healthy at all there. So I'm very gently making sure that the cap is dissected, and then of course the lenticule as well. It's probably much easier to do the lenticule in these cases because it's a much deeper plane, and then I can get this lenticule out. So going on, sometimes you'll have a situation where patient becomes a little uncooperative, starts squeezing, especially if the conjunctiva is wet. and you can start seeing these telltale signs of a potential suction loss happening. This fluid can start creeping in, and these are telltale signs that something is going to go wrong, and you really want to complete the lenticule cut in such situations before you have a suction loss. And you can see I was able to do the side cut, and then probably I was watching when to lift off my pedal, and till the time that you are not into this, you can still go on. Once I cross that area, I'm a little safer. You don't always get away, and best to at this point probably let go and go and come and do the cap cut again. So now the tough part is I'm not sure whether the side cut happened, so I'm just identifying. I could find a very small area of 1 millimeter where the side cut was there. And from here I'm going to go in, and then it's going to be a little tough because instead of the 3 millimeter that I was hoping for, I probably got only a very small area. Of course, the two planes are well dissected, but that area from where I can enter is probably not so well defined. So I will then eventually find a place. And then once I find a small area where I could go in, I can complete the surgery more easily. And this happens nicely, and then I can complete it. So typically in such a situation, it's best to abort the procedure once your lenticule side cut is over, and you can then go back and do the cap cut again. Here I wanted to just pause, and I'm going to stop my presentation and invite Dr. Ramamurthy, but I'll ask the other panelists who are sitting here, what would you do? Because on the SMILE platform, we can do this. You have a cap cut and you can repeat a cap cut. What happens to Silk and Clear and other platforms, which do they also have? Silk, I know, has a biconvex lenticule, and probably if you abort during this stage, you can't go back and do it, if I'm not wrong. But those who are experienced in Silk, and I know that you all have machines of that kind, and also you have Clear, and Dr. Ajay also does Silk, I think. Can you go back? What happens to you when you have a suction loss kind of a situation like this? Maybe you can now come here. Ma'am, Dr. Chitra, you can also come here. You have to go? But you have to talk, because?
No.
Okay, then come and sit here and at least take part in the discussion. Dr. Ajay, please come. Kumar, come.
In Silk and Clear, we don't have that ability to, have something like the Circle software to complete it. But since we have all of them, what we have done is brought them onto the Visumax and done it. And we
So
are
then
also
you can,
wary of the
you'll
fact,
be able to create a flap, right?
Yeah, we have to create a
So
flap.
what I wanted to know was, suppose you had started the second cut and
Okay.
it's a biconvex. So what is because that now it's not going to be planar. So how much, do you know how much is the cap in the center and how much is it in the periphery? For example, Silk, suppose you're doing a Silk and your, the second pass was almost halfway through, and then you have a suction loss. So because it's going to be a variable thickness, right? And if you have, like in the central area, say 100, 120 microns, in the periphery it's going to start becoming thicker, and then you need to be at least 30 microns off that plane. How are you going to do that?
I think that lenticule, the convex configuration is slightly exaggerated. Though it's figuratively shown like that, the variation is not that much.
Okay.
Maybe a difference of few microns. To be frank, I'm not aware of the exact dimensions.
Okay. So do you put in a cap thickness in Silk?
Yeah.
And is that because it's not uniform, right? Cap thickness will be different in the center. So when you feed it, it's basically what you have in the center, where it is the thinnest. In the periphery, it will become thick anyway. So that's what you are going to assume.
Yes.
Kumar, in Clear, what do you do? Okay. Huh. Okay. Why don't you come here and speak on the mic? So you can create a flap with the same interface. You don't have to change it. And okay. And then is your lenticule biconvex, or is it like plano-convex like in Visumax? It's plano-convex. So it's the upper surface is plano and the lower surface is okay, perfect. Then it's easy to do basically.
The big advantage is the OCT.
Right.
Very, very big advantage.
But is that OCT so sharp that it can get
Yeah, it will go to the exact same plane.
I see. Wonderful. Great. So I think with that, we'll move on. If there are questions, please make a note of them and we can answer them towards the end of the course. I'll invite Dr. Ramamurthy sir to share his screen and start his presentation.
Thank you, Dr. Gaurav, for having me in this course. The topic given to me was dealing with an unhappy SMILE and LASIK patient. I dropped LASIK. When I saw Gaurav's presentation, I thought, oops, what am I doing? But then I thought it will be a repetition, but fortunately, he dealt with intraoperative complications. I'm going to be dealing with the postoperative unhappy patients. So possibly this will sync well with his presentation. What about residual error power enhancement after smile? Whenever there's a residual error, for a long time before the Circle software became available to us, and especially now that it's being offered at no price, certain numbers. Now we do more of Circle. But then when it was not available, we used to do simple PRK, where using the streamlight, go ahead and remove the epithelium and subsequently take care of whatever residual aberration is there, residual error is there. And this used to work very well. It was essentially like the PRK procedure enhancement after a flap procedure also. Invariably, in all these cases, we use mitomycin C for 30 seconds, and the results were quite satisfying. Now, of course, the Circle software has become available. Obviously, when we used to do PRK for a day's time, the patient used to complain of irritation, discomfort, watering, prolonged usage of steroids, etc. Here, we are able to convert the cap of the smile into a flap and lift it up. Basically, there are certain parameters that you feed in, and then subsequently you can see that this is the cap being converted into a flap, and we can lift up the flap. The thickness of the flap is same as the cap, and whatever error is there, then you can go ahead and treat this. The arguments I have against the very simple procedure, very easy to do, and the results are also very satisfying. But what I have against it is that, all along you have been promising the patient a flapless procedure, and now you are making a flap with all the vagaries of the flap. And the other thing is, when you're doing it in the smile, if you're doing a PRK, it is basically only the stroma in the cap itself that you're using. The underneath stroma thickness is not used. But in this case, you are lifting up the flap and subsequently using up a little bit of the stroma, and maybe this has a propensity to biomechanically weaken the cornea more than a PRK procedure on the cornea. There's no scientific evidence for what I'm saying, but this just sounds logical to me. But having said that, now because the Circle software is available, more often we use that. Retained lenticule segment, Gaurav very nicely showed what he does on the table when he has a problem. But in case the patient has come post-operatively, therefore this was a very simple case of minus 1.5 diopter spherical error in both eyes. The girl underwent treatment in both eyes, and basically one of my associates had done that, and he did realize that he had left behind the lenticulus were not completely removed. So he removed one part of the went inside and removed what he thought was the balance of the lenticule. But on the first post-operative day, this was the refractive error. You can see -2 with a -3.5, and a very typical bow tie over here. The lady was absolutely mad because she came with a 1.5 power, and this is what we ended up with. And we thought this will be a retained lenticule. I had a look at the video of the primary surgery, and subsequently this is what we decided to. This was on the first post-operative day itself. We thought there must be a lenticule remnant in the center because it was not getting delineated. Injected some triamcinolone acetate, and that really showed up the lenticule very clearly. As you can see, this is essentially the lenticule which is right in the pupillary area, and we had to, this was stuck onto the back of the cap as it usually does, and we had to peel it off that. And you can see basically what had happened was the surgeon had taken off one half of the lenticule, then thought he had taken off the second half, which was the inferior hemisphere, but in between there was a strip of lenticule that was left behind, which was causing the problem. So we had to go in again on the first post-operative day, remove it, and very gratifying results, maybe because the steroids also that went in, that there was a plano refraction with a 6/9 visual acuity on the first post-operative day. Most importantly, the vertical bow tie, that oblique bow tie that you saw in the earlier picture, it completely disappeared, and even this settled down over time as we followed up with serial topography. Retained lenticule 2 months post-op from a patient who had been done elsewhere. Basically, this is the history that was available to us, where a simple 2.75 3 diopters had been corrected. The left eye, the procedure was uneven full, and the vision was 6/6. In the right eye, the uncorrected visual acuity was 6/36, and even the best corrected visual acuity was only 6/18. And there was a very irregular refraction. The patient was not really referred to us, but then came to us looking for a solution. So we did not have complete access to the data or the surgical video. Whenever you have a retained lenticule suspected, it's always a good idea to review the primary surgery video carefully, and most often it will show up as to what went wrong. But when we correlated the findings, what you can see over here is that the patient has 45 point, very steep cornea on the temporal aspect, while on the nasal aspect is flat cornea, which gave us an idea that maybe there was a piece of lenticule left over here. And also when we looked at the corneal thickness, the pachymetry, you can see again there was a significant difference in the pachymetry, 491 and 542, and obviously there was something left over in this quadrant. And again the AIOC picture again showed us there was possibly a lenticule fragment here, quite clearly delineated. And most importantly, just in case you don't have access to these things, just a dilatation and a simple slit lamp examination shows in retroillumination that you have a clear cornea here, while in the area where there is a residual lenticule, there is a very rugose picture that is seen because of the disturbance in the corneal texture. So essentially we just went back again, did not have to use triamcinolone because here we knew exactly where to look for the lenticule, and that's essentially, this is being opened up almost 2 months after the primary surgery, and that's the lenticule that's being taken out. And can I take a couple of minutes? That's the lenticule that's taken out, and immediately the patient's problem settled down. This was what we saw prior to the surgery being done, and once the surgery was done, you can see the cornea is flattened out quite uniformly and obviously with good results. Iatrogenic ectasia post-smile is extremely rare, and but here is a patient where it is quite a significant error that we have treated bilaterally, one eye minus 8.525 with 2.25, absolutely pristine cornea, and both in the right eye and the left eye. The power treated in the left eye was quite significantly less, and both the corneas were quite good. Nowadays, when it comes to -7, -8 diopters, I would rather think of a phakic intraocular lens because the quality of vision it offers also. But this was done almost some 8 years back, and 4 years this patient was living in the UAE, and he went away. 4 years later, he came back with -6 diopters and -4 diopters in the right eye. And you can see there was a full-blown iatrogenic keratosis over there. Fortunately for us, left eye was doing still very well with a plano refractive error and a 6/6 visual acuity. We went ahead and did a intact procedure for him. I'm going to skip the video, and did a cross-linking also along with that. And this is what we found, where not only the error came down, but most importantly, the best corrected visual acuity improved to 6/6. It's a more centered cone we have now, and the fact that it was improving with the refractive correction gave us the confidence. And 1 year after the surgery, you can see the follow-up. This was immediately after the intact, 6 weeks later. This was 1 year after that. Once we knew that the difference map showed there are no further topographic worsening and the refractive error also remained stable, we went ahead and implanted a toric phakic intraocular lens. So this is a patient who came for smile surgery, developed keratosis in one eye, then subsequently we had to do topo-guided PRK with CXL, and finally a year later we could rehabilitate him quite completely with a phakic intraocular lens appropriately placed. And this is what, and the surprising aspect is, even though the left eye had a slightly lesser refractive error, right through the 10-year follow-up, the left eye remained pristine and nothing really affected it. So both the eyes had undergone the same procedure in the same center. And post-smile epithelial ingrowth, just to show you, sometimes you have this problem, and very rarely so. And here what we do is to just go ahead and access that area, scrape it off, and then put some 20% alcohol over there. That's what is needed, and not the mitomycin C, because you want to kill the epithelial cells over there. And once we did that procedure, then this is basically that epithelial ingrowth being debrided off, and then subsequently washed with a diluted 20% alcohol. And one day post debridement, this was the picture, and you can see that this is gone. And 6 weeks later, this was hardly seen. DLK post smile is also possible. I'm going to close off this. Handling is something similar to what you do. This is just an incidental post-op day 1 epithelial defect. Obviously, patient came with a lot of irritation and discomfort. Placed a BCL for 3 days, and this sort of subsided. And apart from this, of course, post-operatively, we faced the complications of dry eye, infectious keratitis, TLSS, etc., which has to be dealt with appropriately. Thank you so much for your kind attention.
Thanks, Dr. Ramamurthy sir, for those very nice videos. One quick question before Dr. Chitra takes over. Like, how common, because you do very high volume lenticule extraction in various platforms, how often have you seen epithelial ingrowth? Because compared to your LASIK practice, isn't it like almost...
This is only one of 2 cases.
Right. And
This,
what do you think maybe the reason when it does happen?
I think
what might be the etiology?
it's possible that there is some amount of epithelial cells which are dislodged at the site of the incision, and when you're going in to dissect out, maybe you're taking in some epithelial cells, and that's why. And because the incision size itself is very small, maybe that's one of the reasons that the ingress of epithelial cells is less here compared to a conventional flap surgery.
Absolutely. So, do you practice washing the interface at the end of surgery? Because some people like to do the wash. Some people say that we don't want to do the wash. I'm just wondering whether that has a kind of,
We were washing initially, then in between we stopped washing. Then when we started doing clear, then they suggested wash it, because initially the results were not that great and we had to iron out the wrinkles. Now I have started doing it routinely. Actually, I do what you do, in the sense that what you have suggested, in the sense the hydro expression of the lenticule. So once it's separated, I just don't go in with a spatula, but go in with a flush of fluid. That sort of brings out much of the lenticule outside. And that takes care of the wash as well as brings out the lenticule, and then they just iron out the
I hope you're
cap.
using my cannula. have you bought my cannula for the hydro?
Have any financial
We
interest?
finish this session
No
fast.
financial interest.
The next session you have to come to you too.
Okay.
Both of you.
Yeah.
Do not wash.
I
And
don't
logic?
wash. Ah.
It's not for that, Sonu. I think it's not for that. Basically, when you go in with the dissector and you are going in from the epithelial, the cut, and there is always that small possibility that you are implanting some epithelial cells into the interface, right? Because you're going in and coming out a couple of times with your manipulator, and if you have left something inside, it's just a good idea to have it flushed out. So what I typically do is I go in from the side, push one gush of fluid just near. I go obliquely into the pocket from one side. I put a small gush, it just goes around and it comes out just about like 0.2, 0.3 ml or maybe 0.5 ml is all that is required, but it leaves the interface
It's
clean.
not only for washing the interface, it's also for ironing out the micro wrinkles that may form in the Broman's layer. So once you're pushing in some fluid, there's a certain amount of hydration of the cap that happens. And definitely after the surgery is over, I do a few times I iron over the cap, and I think that sort of smoothens up. It's all, both when I was washing, not washing, I cannot say the results were much different.
Exactly.
So I think for the ironing, he recommends that you use a Merrill's sponge and then iron it out, and then he takes the patient immediately post-op on the slit lamp, stain with fluorescent dye, see the microstriae, and then he also irons it on the slit lamp. So that's the way they take care for the microstriae, immediate post-op, taking the patient on the slit lamp and then staining it. But I think fluid doesn't, it's just the mindset. I think fluid doesn't take care of the microstriae at the Bowman's level. So it is the Merrill's sponge, and then...
I think what works best in your hands is what is good for
yes,
you.
yes.
Right. So I'll invite thanks Ramamurthy sir. I'll invite Dr. Chitra now to speak on her OOPS moments in surface ablation procedures and preempting and managing them right.
Thank you, Gaurav, for this lovely opportunity. And I would be talking about managing surface ablation complications. Basically, ocular surface ablations are either PRK, PTK, or LASIK procedures, LASIK. And the challenges essentially were epithelial healing, epithelial hyperplasia, the post-op pain, and regression. And with the advanced laser technology and the wavefront guided, topography guided, the procedure, the ablation has become very smooth. And now we also have customizable ablation zones. So there is no way of using small zones. So the chances of epithelial hyperplasia is also reduced because there's no big curvature change. And of course, during using chilled BSS, lubricants, BCL after that, and BCL soaked in non-steroidal anti-inflammatory drops. So all of it makes sense. So basically, there are any number of these complications can happen. Intra-op, the pain and the discomfort is managed by chilled BSS, knee pain soaked BCL, and lubricants. And the ablation-relation complications, if you look at it, decentration is practically rare with these advanced high-frequency lasers which are using, and only if the decentration is more than 0.5 from the visual axis can it be of any clinical significance, and the disturbances would be irregular astigmatism, reduced contrast, glare, reduced visual acuity. So you can always go back on a topo-guided mode, enlarge the optic zone, and thus manage those very rare situations. Next comes the under and over corrections and regressions. Now we know that the regressions or the corrections which have under corrections, these are all because of the abnormal healing or the biomechanical changes which are occurring in the cornea. And the risk factors for regression is high refractive error using a small optic zone or an unstable fixation. And the post-PRK regression rate has been seen to be as high as 19%. And if you do PRK on a thin cornea, 40% of the eyes are going to need enhancement after 10 years. So this is a case of a patient with -7 with 2-cylinder in the right eye and 6 with 2-cylinder. The topography was quite normal, nothing of consequence. I normally would not do surface ablation on beyond -6 at any cost, but this was a one-off case. I think the price was an important factor for them. So we went ahead and did a PRK for them. Patient was fine for 4 years, but after 4 years when he came for a yearly evaluation, he had a 1.25 or 1-cylinder in both eyes. And if you look at the epithelial map, you realize that those red areas, those are irregular heaped epithelium kind of picture. So went ahead and did an enhancement by PRK itself, and the patient did well. Epithelial hyperplasia essentially is because of the marked curvature change which occurs in the edges of the ablated area. Or if it is also, if it's a deep stromal ablation, wherein again there's a big curvature change which occurs. And nowadays with our large optic zones and less demarcated contours, these epithelial thickness changes are hardly ever there. But let's understand, if an 18 micron of epithelial hyperplasia, there's actually a 1 diopter of regression which has occurred. And the mechanism is increased cytokine production, mitogenicity at the limbal stem cells, increased keratocyte stimulation, aggressive wound healing response. So there are a number of causes. This is again a very high myo, -8.25 and -8, insisted on getting a surface ablation done. And all these maps were fine. And because that there was the previous figure, sorry. If you look at this, the TBI was in the red. So we decided, and because we were treating a very high refractive error, we decided to do a PRK extra for this patient. The patient came back after 3 years with a very significant reticular haze in the cornea with a -5 residual. You can see on the epithelial thickness map, you can also make that out. So what we did was, the epithelium was not very regular, so we did a TGPRK with 0 power correction for them to regularize the topography. And then after 2 months after that, the patient had a -6.5 refractive error, and we went and implanted a phakic IOL for this patient and managed it. Now, corneal haze is another thing which you have to keep in mind, which are literally things which don't happen nowadays. It's an early onset haze or a late onset haze. The early onset haze should happen within the 3 months. The late haze can be anything from 3 months to 3 years. The risk factors again are high refractive error, greater ablation depth, autoimmune condition, diabetes, vitamin D deficiency, a high exposure to ultraviolet light. So these all patient has not used topical steroid drops at all. You can, there's a way to grade the corneal haze so that you can, when you see on the follow-up, you know how much reduction of the haze has occurred. So how do you prevent haze? We all prevent it by keeping them on steroid drops, and I keep it on a taper regime for 3 months, and intra-op use of mitomycin C, 0.02% for 30 seconds or for 10 seconds per diopter. And we avoid ultraviolet exposure by insisting they wear dark glasses when they go in the sun. So how do you manage haze? If it is just about grade 2, then topical steroid drops would do. But if it is grade 2 to 4, then we would do an epithelial debridement with mitomycin C, which can be done manually or on a PTK mode. And if it is more than that, we'll have to do a keratoplasty. This is the flow chart which explains it all, that how many of these patients, you call them, start them on topical steroids, call them back after 1 month, and then again after 12 weeks, check their intraocular pressures, see they are not steroid responders. If there's superficial haze, just do a PTK, remove that, and then with mitomycin, place mitomycin for 1 minute I would place, or you do a PRK with PTK. Vitamin oral cysteine and Saha and losartan have some claims of treating haze because they decrease the myofibroblast proliferation. And this was again a case of an early haze. It's -3 refractive error, that's all it was. So we went ahead and did a PRK, primary PRK, and the patient came back after 2 months with an uncorrected vision of 624. And you could see the epithelial map was also very irregular. And even on the ASOCT, we could see some patchy areas which were noticed. So we went ahead and did a PTK with mitomycin C and kept mitomycin C for 2 minutes in these patients. And the vision did improve, although they did not come back to a 6-6 status. This another patient post-PTK had significant haze, and we again kept this patient on topical steroid drops and did a PRK extra. Primarily, we did a PRK extra for that patient, and the patient had significant haze and had a vision of 612 when he came back to us after 7 months. So we went ahead and put him on low-dose steroid drops for 6 weeks, and actually that seemed to be enough to take care of the patient. Dry eye is another thing which could happen with surface ablation, though less than in femtolasic and probably SMILE. But we need to keep them on higher end artificial tears, which has more viscosity, treat the secondary causes like MGD, allergies, and keep them, sometimes they do not doing well, put them on cyclosporine drops or even punctal plugs. So infectious keratitis is the last thing which has to be covered because we have debrided the epithelium, and this was a patient with retinal refractive error, got treated with PRK and came back in 5 days with this kind of cornea and infiltrate and hypopian. So we went ahead and did a corneal scraping and sent for culture sensitivity, which showed as pseudomonas. But before that itself, we started them on broad spectrum antibiotics and steroids and atropine, and the patient did improve a bit, and then we had to do a transplant procedure after that. Sterile corneal infiltrates, again, very rare, which could happen because of the response to the circulating antibodies or immunologic response to meibomian glands. So herein again, you could just scrape them off or use topical antibiotics with steroids, and all of them do significantly well. And last is the corneal ectasia, which is practically rare after a PRK procedure. But this was one patient who had ectasia, as you can see here, and we went ahead and did a topographic regularization, and the patient uncorrected from 624 came to 612, and the corrected vision came to 0.7566. Steroid-induced glaucoma in myopes we have to always be conscious about, and prefer to use low-potency steroid drops and keep a watch on these eyes. Thank you very much.
Thank you, Dr. Chitra, for those very important points. While I ask Dr. Ajay Sharma to please take the other podium, I have a couple of questions. My friend Dr. Kumar says that he doesn't enjoy doing surface applications because he has that, fear of the haze. I just want to ask you, how often do you get haze?
No.
And has trans-PRK made a difference? He does now mostly trans-PRK is what I know, right? So did you see a shift? I mean, what benefits did you see when you moved on?
I think, of course, in LB Prasad, they do high myopic correction. We just don't do beyond -6. We easily are able to convince our patient to go for a phakic IOL if the cornea is thin. So, and we keep them on steroid drops 6 times for 2 weeks, 4 times for 2 weeks, and twice for 2 months, altogether 3 months. I rarely see haze. If I see some haze, it's of patients treated elsewhere where they have been inadequately treated or a higher myopic correction is done. Actually, each of our refractive procedures beyond -8, even if the cornea is very thick, even the femtolasic, I would say, or SMILE should not be done. We have a wonderful option as phakic IOL. Why do you have to weaken the cornea? Because we still have not been able to get into this mystery of which cornea is biomechanically weak.
So for your 6 diopters of PRK, would you use, how much mitomycin would you use?
See, I use mitomycin 0.02%
Per
for every
diopter,
diopter, 10 seconds.
That's the LVP protocol
Yeah.
because they go up till minus 10 or
Yeah,
12.
but if for smaller, even -2, -1, -3, I would do mitomycin C for 30 seconds. It's not that I would not do mitomycin. I'll do it for everybody. Just like in TRAB, I would use mitomycin always. I would do for.
I also want one last question. Like, what's your experience on PRK with people with pure high astigmatism or hyperopia?
Hyperopia we have been very far, and we have done in our earlier days.
For
I
example,
don't.
if you have a refractive surprise post cataract surgery and you want to do a surface ablation, would you?
Yeah,
do
I would do
hyperopia?
it. I would do it.
Do
I
you see
would
more
keep them more
regression?
on, keep the view. Dry eye is a challenge, so I would adequately treat them with high-end drops and would not hesitate to use cyclosporin if the indication is there.
And for high astigmatism, if you have to do a surface like maybe.
Yeah, I don't. I think surface ablation is brilliant, and accepting 1.5 days, and that to be used that Nefanac soaked BCL, which we place for them. The next morning when I see them, I tell them eyes will be watery and all. I see they are all nearly fine.
So are you using Nepafenac soaked BCL now?
Yeah,
Because ketorolac is no longer available. I mean,
Yeah,
Intod stopped
yeah.
making.
So that's what we use. We
so
have
which brand of
from
Nepafenac?
Sensus Pharma. We have Nepain, Nepain. In that we soak it.
Oh.
And we put it regularly for the last 3 years. We are putting.
So-
Pain has significantly gone.
So I think Nepafenac would obviously help, but then you know
Sentis.
those very rare reports of corneal melt were from
Right.
Nepafenac, not
Yeah.
from ketorolac. So
Yeah.
the logic of using ketorolac was that and I've been scared to use Nepafenac because there are reports and
No, no.
I mean,
All are centers. PRK is still in. It has not gone
no,
out.
we do a lot of PRK, but
Yeah.
I'm just wondering because we don't get ketorolac anymore, and it does
Yeah.
make a huge difference to the pain score.
Yeah.
Patients are
Yeah.
almost
Anyway, you're going to soaked and then you're going to wash it off.
goes
No.
away, right? Perfect. So I think any question from the audience? Yeah. It depends on what treatment
Which you
you're
use for
doing.
1 minute?
Mitomycin. Ma'am, the Randy Epstein and Parag Majmudar who came out with the protocol was 0.02% for 12 seconds. So that is what is like, in literature it says this is what it is. But if you're doing a high correction, like, going beyond 50 microns of ablation, you can use 30 seconds, and then the LVP protocol is 10 seconds per diopter. So there are various protocols, but you can choose one of them, whatever works.
Only one
Okay.
one information I want
okay.
to share in surface.
So we'll start with, sorry? Yeah.
One information I want to share. One of my patients had done surface, went for a holiday on a beach,
I
and
have
did
the
not
same
wear ultraviolet glasses. You know what happens to the cornea? They come with spicules,
No,
white
proper
dots.
haze.
So it's very, very important that even we take steroids and all that, but they have to wear.
So in the first year, I typically tell them to ensure that they are wearing UV protection whenever they are out in bright sun. My patient who went skiing after 6 months of this thing came back with bad haze in both eyes. So I think we'll invite Dr. Ajay Sharma sir to please go ahead and speak. Yeah, sure.
Thank you, Gaurav. So I'll be talking on the OOPS movement in refractive lens exchange surgery. So we have all types of these refractive surgeries, but at times when everything fails, or means your refractive errors are too high, then this is one of the modalities which probably is really good with the newer and the latest lenses coming in. And this thing has been done way beyond, like in 1776 by Abbey and then by Vincent in 1890. And thanks to the Horrod Ridley, where we got the lenses, and finally it was foldable lens in 1980. So these surgeries can be done now very easily. Indications are refractive errors, like I said, associated with the lens opacity, especially in presbyopic age. High refractive errors where we can't use phakic lenses. Hyperopes in presbyopic age is the best candidate. And now what we have is the dysfunctional lens syndrome. Patients are coming in where they want to see clearly. They feel that they are not happy, and when we find out on various tests, that is the syndrome, and where we want to change the lens. So these are certain considerations which we need to have, because the eyes are long in myopic eyes. In short eyes, there can be if you're giving anesthesia, then there can be a problem there. So normally this is just a very no OOPS moment here, normal surgery here, but removal of the nucleus is by creating wide, deep, long trench with just irrigation and aspiration is good enough. low phaco powers and with moderate vacuum will be ideal, and cortical cleanup has to be very good, and there has to be a capsular polishing because you are dealing with young eyes and young patients where they need to have no PCO if you want to give a good result. This is just polishing and taking the cortical matter out. Lens implantation can be any lens implantation because now we have so many the EDOFs or the trifocals or the monofocal pluff lenses. So that is what. Now the OOPS can be at times, it is just like any surgery. So any cataract surgery, what you have, any moment, OOPS moment there can be similar. So I try to implant this lens in this patient, a young patient, and with dysfunctional lens syndrome. And I thought I'll be able to go through this, but these lenses with 4 haptics and claw type haptics, it gets stuck out there. So I thought, why I need to dilate it? I'll be able to, take this in, but it is getting a bit difficult here. I'm trying, and then finally, when I take one haptic inside and putting in more visco, making the chamber deep, and now like this haptic goes in, and once the one haptic goes in, then the second haptic can go in nicely. Now these lenses can be a problem at times. Now whether it is this, and now once this is gone, then it is easy, you can just go on with that. But again, you have to be very cautious whether that is in the bag because you are not able to see properly. So this is where I'm seeing by retracting the iris. So struck, sorry.
दिल्ली से मुंबई नहीं पहुंच रहे हैं.
So the next is the rent. I think most dreaded complication or maybe oops moment in anything. And again, when it happens in young patients, lens is inside very nicely, no problem at all. Then, but once I'm doing an IA, I just find here that what is this? You can see this. There is a vitreous coming out. I have taken a vitreous tag here, and I can see the lens from here going down, dipping down. So now I have to take the lens out first because I have to prevent this from going down, and maybe do a vitrectomy. Try to place it within the bag. First, I just want to see where the here we have dilated and just want to see where the PC rent is and whether we can put it. And the irony is that it is a toric lens and it has to put in a particular axis, so that situation becomes much more difficult here. So, but we managed to put it there. But be very cautious and clear that you have to do a vitrectomy here. So once I have settled the lens and if I see, so the anterior vitrectomy is being done to take the vitreous out. This can be again a difficult situation in a subluxated lens because these are the patients with certain syndromes where you have the lens which is subluxated but clear sort of a lens, but patient want to definitely go in for a surgery. So you can see here that the lens is subluxated here, you can see here, right? So we did this surgery, and you have to be very careful because this is what is important. So it's slowly you have to maneuver the nucleus, take the nucleus out and put a CTR here. So here putting the CTR, and then implanting a lens in the bag. And this at times can be very difficult, but since the so subluxation was not much, we managed with this. Then it can be the ICL, post ICL. Today after refractive surgery, people are coming with this. So we try to do it one with this was Oaks movement, whether we'll be able to do it with our flags or not. But company doesn't recommend it, but we thought we'll be able to do. We did certain modifications here, and we were through with that. So here, so once we do these modifications, you can have a good proper surface mapping, and now you can see anything. This is the lens ICL here, and this is the induced cataract which patient developed within a week. It was operated somewhere else, and similarly other eye, you need not to do anything, just directly the machine took the surfaces, the anterior, posterior and everything. You need not to do any modification. And here you have to be very clear, but though it is a bit of cataract, but this is again a young eye, a young patient where the cataract has developed as a complication of ICL. So just be cautious, take the lens out, slowly take it out, and you have to straighten it and pull it out by handshake technique like this. Once the lens is out, there is just sort of a cortex inside, and not much of a phaco is needed here. Just how easily, even with IA, we can take that out and implant a lens. Here, implanting a lens again is important. You have to give a trifocal or a EDOF so that the patient again is independent of glasses. So similarly, I think we are running short of time. It can be in our case, just to show that if you have something here, these are so many cuts here, you will definitely have a wound. Will be there'll be cut of the scars here. So don't feel shy. You have to suture it in the end, like here. The wound is here, and we need to suture it, and you should not be closing the surgery without it. That's it. I think we'll skip all this, and but be aware of these complications. We need to know that there can be, because these are myopic eyes, and it can be retinal detachment, and risk factors are there, and myopic degeneration, CME, post-capsular opacification, halo's glare, and all these things can happen. But be prepared. You are doing these surgeries on a person who are young, try to give them the best of the vision, and so you have to be very cautious, counsel them well, and choose a proper lens. Thank you very much.
Dr. Ajay, and please come over, and we'll have a discussion towards the end of the session. So I'll request my friend Dr. Sri Ganesh, who's going to go judge the Rangachari Award, so he has to leave quickly.
Good afternoon, everybody. Thank you, Gaurav, for inviting me to your course. We'll talk on how to manage refractive surprises. Now, of course, after refractive surgery, laser vision correction, now we have been doing almost exclusively SMILE and KLEX from the past 12 years. So I thought I will restrict my talk to the enhancement techniques if you have a residual refractive error after KLEX lenticular extraction. So what are the techniques for enhancement after KLEX for a residual refractive error? You have surface ablation, you can do thin flap LASIK, you have the circle software flap creation, and followed by LASIK, or you can also do what is known as subcap lenticular extraction or re-SMILE. So PRK after SMILE is the simplest procedure to perform. It's ideal for low enhancements. You have to take in epithelial thickness if you are considering trans PRK, and it's always better to use mitomycin C, 0.02% for about a minute. You use it for a longer period of time because you have a higher incidence of haze after lamellar surgery. Advantages of PRK is that you are still maintaining a flapless procedure, and biomechanically it's quite stable. This is a paper by Walter Sukendo, who looked at enhancement after myopic small incision lenticular extraction using surface ablation. And he concluded that when you use mitomycin C and surface ablation, then this is a safe and effective treatment for enhancement after smile. Coming to LASIK after smile can be done with thicker smile caps if you have used a cap of 135 microns or more. And again, this is suitable for lower enhancements. Epithelial thickness has to be taken into consideration when you're planning the flap and the flap thickness. And femtoflaps of 100 to 120 microns are ideal. There is always a risk of entering the previous interface if you use a thicker flap. And ideally, it is not suitable if you have previously used thin caps of 120 or 110. And the hinge has to be away from the smile axis incision, otherwise there can be an overlap. So this is a paper by Professor Dan Reinstein, who looked at outcomes of retreatment by thin flap LASIK after smile, and he concluded that the results were quite good and predictable and patients were comfortable. Then you have the Circle software, which is a very special software for enhancement after smile. It's available on the Visumax. It allows the surgeon to convert a smile cap into a flap, and it has the this is the configuration. It's got 4 incisions. The first one is the lamellar ring, the second is the side cut, and third is the junction cut. So it's got 3 cuts, which is done by the femtosecond. It's not available in the US, it's not FDA approved, but it is available in India. So you have different patterns for the circle treatment, A, B, C, and D. The D pattern is what we commonly use for enhancement. This is a video. You can see that's the lamellar ring and the side cut and the junction cut. And it converts the cap into a flap. So then you can shift the patient to the excimer laser. You can open up the flap and you enter into the previous interface. So you'll have to know the depth of the previous interface and then set it in the machine. Here it was 120 microns. And then you can lift the flap, and once you lift the flap, then it's like your regular LASIK. You use the excimer laser to do the ablation. Sometimes it can be a little sticky at the side cut or at the lamellar cut, but generally you are able to do that, and that's the ablation. These are a few papers of the circle pattern for creating the flap and doing the treatment. In our practice also, we prefer this technique because normally use a 110 or 120 cap, and this is very useful. And of course, in this series by Chan Sui from Thailand, he concluded that it is quite safe and can be used effectively. And Jodhbir Mehta and his group compared the 4 different types of patterns, and they said that again the D pattern is probably the safest and best for doing the circle software. Then you have smile and smile or re-smile or sub-cap lenticule extraction. Can be done if previous cap thickness is known, can be used for higher refractive error enhancements. Epithelial thickness has to be taken into consideration. The advantages, you can still maintain a flapless procedure. So how do you do it? It is not an approved procedure. After the refractive cut is done, and the side cut, then you just stop the machine, you put off the suction, and then you just access the original incision. The old interface is the superficial plane. It can be very easily opened up. The deep plane has to be dissected carefully, and the lenticule is extracted. Minimal thickness of the lenticule should be maintained. So usually if the enhancement is very low, if it's like a 0.5 or 0.75, it's not ideal. If for higher enhancements, more than 1 diopter, then you can do this technique. You keep the minimum thickness at 30 so that you don't have too thin a lenticule, and it's easy to dissect and remove. And of course, you have to see the residual stromal bed. Centration is critical, and then you can use a smaller optical zone. This is one of the cases, pre and post-op enhancement with the re-smile. You can see that the flattening has increased. This is the video. So after the lenticule cut and the side cut, you just put off the suction, you go in and access the original incision, and you can see that's the deeper plane which you dissect. Superficial plane, you don't have to dissect, it's like very easy. So this is a deeper plane being dissected, and once you dissect the deeper plane, then you can very easily remove the lenticule. This was a patient whom we had done monovision, and she was not happy with the monovision, a high myope, and then so she wanted a full correction, so only one eye we did that. And these are the first reported case was by David Donate, who did this technique. He called it subcap lenticule extraction, and it's published in the JRS. Jodhbir Mehta and his group looked at tissue responses for different techniques, from PRK to LASIK to subcap lenticule extraction, and of course they have described the various advantages of and disadvantages of each technique of enhancement, and you can go through this if you're interested. So that's about enhancement after smile. Thank you very much for your attention. Thank you.
Thank you for those nice tips. Kumar is going to start his presentation. We are a little behind schedule, but I have done a few cases of smile on smile when there's a suction loss, and typically the company obviously recommends you can't, but you have to really plan it, because you can do three things: decrease the lenticule thickness, decrease the cap thickness, and decrease the optical zone a little bit. So you get about 25 to 30 microns, you can do smile on smile, aborted smile basically. Wonderful, very nice presentation. Thanks, Vikanesh. Kumar, please go ahead. Dr. Kumar has a long oops with the oops moments.
So some of flap complications I'm just going to quickly show. Can I have the audio? So we're going to go fast because this session has to finish by 2:20. So first one is patient comes next day. This was a normal microkeratome.
Flap infold noticed a few hours after surgery. The flap is everted. 2 dry sponges should be used to iron out the folds on the back surface of the flap.
So this was immediately after surgery. Then you don't need to worry.
The use of hypotonic saline is used to hydrate the flap and hence assist to iron out the folds. The direction of the movement of the sponge to iron out the striae should be perpendicular to the direction of the striae. The flap is placed back. Notice the vertical fold, but this will not be seen on the next day. On examination on the next day, the vertical fold disappears. Another case of a nasal hinge and a decentered inferior flap noticed after the first 24 hours, in which the epithelium...
So here we remove all the epithelium, and you can see that the whole flap has got decentered and gone down. It's a nasal hinge. I have a Schwind microkeratome, so you can do a superior hinge or a nasal hinge.
Ironed with the use of hypotonic saline and 2 dry sponges. The hypotonic saline is used to hydrate the flap and iron out the folds with the same action of the 2 dry sponges. The flap is repositioned and these folds disappear the next day.
Now this is a case of epithelial ingrowth, which is very little. It's only on the periphery, so you can see that that's the area where the ingrowth is. So you just have to lift that area and clean it, then that's fine. So then there is nothing to worry. So you can see this is larger epithelial ingrowth. Here we will lift the flap, evert it, and then scrape the back.
The stromal bed is scraped off of all the epithelial cells possible.
Don't forget the back surface, and you will see this thing peeling
The back
off.
surface of the flap is then tackled off the ingrowth. The flap is gently held with the help sponge, and then the ingrowth is slowly, gently being peeled off.
And this does very well. As mentioned by Dr. Ramamurthy, you can use 20% alcohol, but normally first attempt I don't do anything and it goes quite well. And it just comes off. Once it is off, just place the flap back and you're fine. Now I'm going to go to another one case. This is patient has come after a week, okay? And there are a lot of wrinkles right in the center.
After day 7.
So
For
you-
a good iron out of the wrinkles, the epithelial
So if there are wrinkles in the center, in the optical zone, in the pupillary area, after 7 days, there's no other option but to remove the epithelium. But you have to know the pre-op flap thickness. So if you have a flap thickness of 100 microns, you have 60 microns of epithelium, then what you're dealing with is only 40 microns. So you have to be very, very careful.
essential on the central optical zone.
And these patients do extremely well. The principle is the same. Remove the epithelium on the optical area. Make sure the thin flap is lifted. Again, irrigate both sides 90 degrees to the wrinkle. And once that is done, place the flap back and epithelium comes back. And the patients do quite well. I'm going to show you one flap complication. This patient had RK and we had done LASIK on that. And once the LASIK was done on that, the patient came next day with a torn flap. Okay? So here you don't need to mark. The reason being here is that you can see that just remove the epithelium from the side. And you can see in a torn half flap, it's going through the pupillary area. You'll be surprised that I cleaned everything off, removed the epithelium, realigned, because the RK marks itself helps you, so you don't need to be confused on the right side, up or down side. It really doesn't matter. Just align the RK marks and that's going to be well. And you can see it's going through the central area. So done all this, aligned it, put it back, and once I put it back, all I did is irrigated it and then put a contact lens. I did not take sutures. Normally one may need to take sutures, but you'll be surprised. I kept the contact lens for 3 to 4 days and this completely disappeared and the patient was doing extremely well. I'll show you one last case. A decentered femtoflap. This was the 4th case of my career. I started LASIK femto around, this was on the Z4, this was about 11 years back. And you can see a decentered femtoflap, the hinge is in the pupillary area. So it's very important to understand the mistake I made. The mistake I know what I had made is the relation to the technology that you're using and how you're using it. So it's very important to understand that, but you don't need to worry. So I've actually cut the conjunctiva, the hinge is at the area of the pupil. What you do is go deeper. So if your initial cut was 100 microns, you make the second cut at 130 microns. Do exactly the same thing and then lift the area away from the area where it was originally there. So you can realize that I've started to lift. I made a femtoflap and I've started lifting it from away from the area where the original cut was. And then you'll get your plane. Once you get that plane, go ahead and do your ablation and everything goes very, very well. So nothing to worry. If that happens, you can easily go around and take care of that. Thank you.
Presentation, you covered up almost all these complications and very nice cases. So our last presentation, I'll invite Dr. Sonu Goyal for his oops moments with phakic lenses. And I see that our next session, people are here. We'll just try to finish it fast because we got 5-10 minutes late, but we'll finish in before 10.
Thanks, Gaurav, for making me part of this course. So I think there is some oops with the AV team. Huh? Can we have the AV plugged in, please? So I think when we talk of the ICL surgeries, the biggest challenge for, so yes, we are placed. So oops in ICL surgeries. So I think when you're talking of refractive surgeries based on ICL, the biggest problem or the biggest oop would come either from the sizing or from the surgical technique. So we all know that we are very, very cautious for avoiding these conditions when you have an excessive vault or a very low vault. And here is one of the patients who came to us. This is a 26-year-old female with a refractive error of -4 with -0.5 of 180. The keratometry readings, the PECI, the anterior chamber depth, close to 3.3. What is more interesting is the white to white, 11.65, and both the eyes. The wall prediction by the Lasso formula. So we use an IL Master 700 here. And the predicted vault using an IL Master 700, using an ICL size of 13.2 came out to be close to 724 and 729. So we sent the data to the Star Surgicals, and with their OCOS, they came up again with the same size of ICL 13.2. And so we went ahead and we took this patient for the right eye, and this is how this was 13.2 ICL. And very carefully, we use the sponge here, avoiding any touch to the delicate lens. And specifically for low diopters, the optics are very, very thin, so care should be taken to avoid pushing, pulling, or trying to catch in the center. This is a good trick to put in viscoelastic, avoiding air. And then calibrated incisions, so 1.1, 2 side ports we do, and the size of the main incision always has to be 3 millimeters. I don't do a wound assisted, always advocate that the injectors should be slightly within the anterior chamber so that it gives a good control, and at times you can rotate. So looking into the 3 holes there, just this lens was pushed. I have an access to an intra-op OCT also. So once this lens was in place, we took this patient day 1, as we routinely do in all our patients, for the vault measurement. And to our surprise, the vault came out to be 1330. So that was quite a surprise. But luckily, the angles were open and the pressure was normal. Now, this was a toric lens. Now, the trick was that what should be done for the other eye, which is to be taken the next day. So this is where we take this patient, and we are doing the second eye on the second day, and we are keeping in, quite worrisome that the vault might be high. So we push in viscoelastic, try to settle the lens, but this time I have an access to the intra-op OCT, and so keeping in mind the vault to be nearly the same in this patient, because we tried to get one lens lower, that was not available. So what we do is we rotate the lens. This is a non-toric lens, and we try to rotate this lens vertically. So just see, from close to 900 intraoperatively, it came down to 700 with this intraop OCT. So rotation with the non-toric lens, putting the lens vertically, might help in getting the vault. See, now there's a reduction in the vault, which is close to 700. And this is the vertical orientation, as you see the 2 holes, and on day 1. So we were able to achieve adequate vault in the left eye, which was close to 973 on the anterior segment OCT. So sizing is very, very crucial, and what is more important is this table that I want to bring in, that with the star, the moment the white to white shifts from 11.64 to 11.65, the size of the ICL shifts one size up from 12.6, 13.2. So I think this was one of the major contributors for the refractive surprise or the vault surprise that we have. So is there any way to predict the vault? Yes, we have a lot of vault prediction formulas, the Lasso, the Reinstein, the KS, the NK43. Routinely what we use is Lasso, and we also recommend all of you to use this formula. A very simple formula. Online you go, feed in the patient data. What is important is a refractive sphere which has to be fed in. Then you feed in the anterior chamber depth. So you can use either the data from the MS39 or you can use the data from the IOLMaster 700. So we feed in the ACD data here. After the ACD comes the lens thickness. Then comes in the white to white on the IOLMaster. Then you feed in the K readings, and both the K and the K2 readings. This is the IOLMaster, the central corneal thickness, and then you have the pupillary diameter, and then this will give you the vault with different sizes of the ICL. So for example, if you have an ICL of 13.2 size, you will have a predicted vault of 773. So I think this works very well and helps in avoiding those outliers, maybe a small, maybe a low or a high vault. Recently, I think thanks to Gaurav, who shared us this wonderful tool, which is called, with your permission, Gaurav, I'm using this here. And this is a wonderful tool, ICL calculator. And this is actually an online calculator which helps you in giving you an adequate size and predict the vault. The beauty of this equipment is this is available online freely, and you can change the equipment that you're using. For example, if I use an IOLMaster 700 here, it'll actually give you what is the white to white adjustment and what is the anterior chamber depth measurements that you can change or that are required. For example, an eye trace, see the calibration white to white and the anterior chamber adjustments are calibrated. And then you can feed in the right and the left eye data. You can calculate and take a printout of the required size of the ICL. So I think all in all, the adequate size calculation is very important when you're dealing with these phakic lenses. So thank you.
Thanks a lot, all the speakers, and thank you for being patient from the next session. And we'll hand over the stage to you right away.